And it's about patients and discussing treatment approaches to patients. So the best place to start is always with having a case presentation. Andreas, if you can take us through the presentation of today's case that will form the basis of our discussion.
So I think this patient represents a fairly common patient, which presents with TR, an elderly lady, 83 years of age, presenting with dyspnea, initially also with edema, multiple valve diseases, a TAVR treated in 2020, pacemaker implanted after that, then a mitral tear in 2021. She has a persistent atrial fibrillation and some, I think, minor coronary artery disease not requiring treatment with intervention. She is on a quite substantial heart failure medication. As you'll see, it's a quite complete list, including a rather high dose of torosamiide, as you see, which is equivalent to maybe 150 milligrams or something of furosemide. So it's a quite ambitious medical treatment that was instituted to treat her symptoms, but there were remaining symptoms despite this. If we first think about the surgical option, which might not be the first thing to come to mind, but still should be considered, I think, in some patients, if we go to the TRI-score calculator that was developed in France, as you know, and published about a year ago, we don't have too many points, but still we get a point for age over 70, functional class 3, high dose of furosemide or equivalent torosamiide, and the slightly decreased LV function. It gives you 5 out of 12 points, and that actually gets you a 14% predicted in-hospital mortality. As you know, this is a score that is developed specifically for tricuspid surgery. Then on the right heart cath, performed about half a year ago, you'll see a moderately elevated systolic PA pressure, a wedge pressure that's also a little bit elevated. The cardiac output is not too bad, and you'll see that the pulmonary vascular resistance is actually low, and the RA pressure not too elevated either. So maybe not, from this you cannot really derive that there is a torrential TR or something like that, since the RA pressure is not that high. But you'll see it usually falls into the acceptable range of patients where you would expect that you could derive a benefit from treating the TR. On an echocardiogram, which was done recently before the procedure, we see a mildly reduced EF, a normal-sized left ventricle, just mildly reduced right ventricular function with a TAPS of 19, so almost normal. Both atria as expected, large, which is very common in this population, and as you know, a very high prevalence of atrial fibrillation in this population. The previous...
Afterwards.
No, I mean, I think, we want this to be as lively as possible, and discussion is important. So I think there's something you have a question about. Let's address it now.
Well, I had a question about the previous slide on the TRI-score calculator, because you didn't activate the right-sided heart failure signs in the tricuspid patient, so no edema, no ascites,
Marianne has seen
nothing?
the patient.
Yeah. According to the definition, we don't have severe edema, we don't have ascites or anything like that, and that's why we didn't check that point.
Only mild symptoms of right-sided heart failure.
Exactly. And,
okay.
You're smiling.
Yeah, we could debate if the score should be even higher. I agree on that.
Then it would be
even higher.
To make it even more difficult, the DFR is exactly 30, so we are on borderline there too. So it's at least 5. Let's call it like this.
I guess most people would say it's probably not the first option to go for surgery for such a patient.
Absolutely.
For sure. Let's see, coming back here, going through the echo findings, both the previous valve interventions show a good remaining result, with a good result after a TAVR, good result after mitral tear last year, and the PA pressure measurements are the same more or less as on the right heart cath. So unchanged despite diuretic treatment in this half year between these two investigations. Now going through the TOEs, this is transgastric picture. And I think the right picture should be, it's a slow motion without color. You can appreciate where the color is. It's mainly, I would say, central between the septal anterior and a little bit towards the posterior too. It's a little bit hard to see where the pacemaker lead is, I would say, but it's probably up between the posterior and the septal leaflets as I see it here. But you see it a little bit in the central part there too. It doesn't seem in my eyes, but I think we get more detailed analysis on it later. The gaps don't seem to be really big. Checking on the result of the mitral tear, no problem there. This is transthoracic echo just to assess the size of the TR, and you might see that the vena contracta was measured to around 9 millimeters. Now the procedure starts, and this is intraprocedural TOE with transgastric again, showing more or less a similar pattern to before. We can discuss, I think, the details of this, if it's a good candidate for TEER or for some other kind of tricuspid treatment, so I won't go into detail on this now. More transgastric imaging showing again the pacemaker lead being up in the posterior commissure mostly. And here again we have vena contracta measurements, which I think are around 9 millimeters still, maybe a little larger. I think the PISA was measured a little larger than 9 millimeters on this imaging. Okay, thank you.
So Nina, maybe you want to take us through a little bit the procedural analysis and discuss the strategy and procedural plan for this patient.
Thank you, Azim. So I had the chance to look a little bit closer at the valve morphology. You just had a couple of seconds to really look at the valve features. I'm not sure if you can get the smart screen images on the big screen. Is that possible?
We're going to have to do it over here.
So otherwise it's very difficult for you to see. So we have still frame images, and according to what I have seen during my analysis, so we have a 4-leaflet valve. So we have an anterior leaflet over here. We have a P1 here, and we have a P2, and we have a septal leaflet. So this leaves us with a 4-leaflet valve, and this might be a little bit more complicated than just treating a 3-leaflet valve. So another thing, if you look at the gap size, so we had two major origins of the tricuspid regurgitation. So one is more to the central part, closer to the anterior and septal leaflet here, and the next one was extending here to the posterior part. And if you look at such a morphology, which leaves us with a 4-leaflet configuration, as you can see in this red bar here on the red side, and you add an anatomical factor like a larger coaptation gap, which is not that big here. The gap is not the problem in this specific case, but we have a TR jet origination, which is extending to the posterior part. So this gives us an additional morphological factor that we have to take into consideration. And if you look at the results, if you have such a constellation, this would bring us to a scenario where you have to expect a residual tricuspid regurgitation in up to 45% of the patient. In the specific case, I wouldn't think it's that high because the gap size is not that big. And what we've seen and what's on the positive side, we don't see a lot of tethering. So the amount of tethering was very small in these patients. So let's come to the next slide. Okay, so let's speak a little bit about the strategy. So if I looked at the case, I had the impression that it might make a lot of sense. You have two jets, two major jets. One is more to the middle of the valve. So my impression would be maybe start with a device in this region here, but you still have this posterior origination of the jet, so this is something you should address. And you might think you need a second device maybe in this region. So just have a look what's positive in this case. What positive criteria do we have? So I think what's positive, we have a really nice length of the septal leaflet. This is something you have to grasp, and this is really nice. What's also really nice, we don't have a lot of tethering, and we have a gap size which is not that big. So it's in between 5 and 6 millimeter. So this is definitely on the positive side. Another thing, the pacemaker lead is positioned here in the posterior septal commissure, and it's not involved in the mechanism of tricuspid regurgitation. So I would think we don't have to think about too much to think about the pacemaker lead. So this is also on the positive side. We also might have some negative aspects here in this scenario. So what might be negative? So a 4-leaflet tricuspid valve is more complex than a tri-leaflet tricuspid valve. You might have to put 2 clips in here, as I've already mentioned. This would be my first strategy here. What's also maybe worth to mention, the posterior leaflet here, the P1, which should be connected to the septal leaflet here, is a very long leaflet, but it's not very broad, so it might be very difficult to grasp that leaflet. There was another thing which wasn't really nicely shown, but the pacemaker lead, there was a pacemaker lead in the atrium which really made a big loop, and it was in the course nearly parallel to the mitral valve. So the pacemaker lead was not involved in the mechanism, but if the course of the pacemaker lead is really parallel to the mitral valve, you may have an interaction here with your devices. So this would be my concerns. And there was another thing, because we heard that the patient had a TAVI prosthesis in place, the patient had a mitral procedure in advance. So this might cause shadowing, which can also affect the imaging quality during the procedure. So in summary, I would think, coming back to what Jörg Hausleiter said, well, it's a 4-leaflet valve. We have 2 major originations of the jet. I think you would need 2 devices here to adapt and to cover all the lesions we have to cover. But in my eyes, it's not a very simple procedure because of this very specific scenario that I just addressed.
Nina, thank you. That was a fabulous analysis of the case. I think we're going to try and finish the case, and then we'll come back and answer all the questions. Is that okay? Perfect. Yeah.
Yeah, so we will now jump into the procedure. So we are already located in the right atrium with the PASCAL Precision ACE. And the first thing we do is a really moderate gaining of height maneuver by rotating the guiding catheter counterclockwise and the steerable catheter clockwise, just to make navigation a bit easier, that we don't interact with the tricuspid valve. And the next step is to check the path by moving the implant catheter, which you can see here now. We're actually quite happy with the pathway so far, and so the next step is now to go into the transgastric view, which you can see here now. You can see the tip of our PASCAL in the short axis view at the left, and you can see that we're still above the valve on the right. We have to keep an eye on that. What we now did was rotating the paddle knob and opening the device. And now we are positioning in the anterior septal coaptation line, where we put in our first device. As we just heard, we are rotating the implant catheter, and this is where we're ending up. Just to show you again, we've just done that, but we have to check the clasp, so we have to be sure which slider belongs to which clasp. And as we know that, we can proceed and advance the PASCAL Precision into the ventricle, so just underneath the tricuspid valve, which you see here now. We usually advance through the valve in the transgastric view, just to make sure that we stay in the position we wanted. That just happened. And now we will perform the clasping. We do an independent clasping with the lateral leaflet first. We have some shadowing here due to the ventricular lead, and we have already clasped the lateral. And now we have performed the Tarzan maneuver to the septal, and now the septal clasp is also down, and we are rotating the paddle knob to close the device. We are back in the RV view, RV inflow-outflow, to assess the residual TR. And for me, the most important thing is that we don't have any residual TR anterior to the device, which wasn't the case. And we have a gradient of 1 millimeters of mercury, which is also good. And this is the position we achieved. Our plan was to be just anterior to the papillary muscle, so as central as possible, and I think we have achieved that. You can also see the leaflets in the device. And now we are releasing the device. You can see the redesigned handle on the upper left image. We have removed the cap, and underneath there are the suture locks, which are now unscrewed, so the two whitish caps, and it's pulled out, and the same is true for the second suture lock. And the last step of the release is now the release knob, the blue one. It's also rotated, and you can see in the fluoro the release of the PASCAL ACE. Now the steerable catheter, the implant catheter are retrieved. We usually fix the steerable in that position and advance the guiding catheter, so the guiding stays central in the right atrium. And so this is the result after the first PASCAL. We were quite happy. That's exactly what we expected. We have a central to posterior residual TR. And that's what we are planning to address with the second device. It's also a PASCAL Precision ACE, as you can see here. We are here just double-checking if we are interacting with one of the pacemaker leads. And as Nina just said, the ventricular lead is just crossing the valve with this loop, and then it makes the navigation a bit more tricky, but we didn't have any interaction. So this is the next step, and you can see that I applied too much flex to the steerable, so the pathway you can easily see on the fluoro image, so the pathway isn't ideal. And I was also located too much anterior, so I pulled the whole system and pulled the steerable to go to the posterior side of the valve. And now I'm checking again the pathway, but still the pathway isn't as good as it should. So there's some further unflexing of the steerable here, and it's becoming better. Bit pulling to go posterior, and now we're approaching a good pathway. So the next step is to open the device in a capture-ready position and check the clasp, as we did before. You can see that here we have to rotate the implant a bit. We do that with the fluoro because we have the other device implanted yet. We can have a look at it and orientate. So this is the clasp check again. And we actually did the clocking in the transgastric view, which you just didn't see. Sorry about that, but we come to that in a second. And this is again the independent clasping, first of the lateral, as we just did before, and then of the septal. So again, tarsal maneuver. I wasn't too happy about the septal because I think it rolled, and you have to avoid that. So I'm improving the insertion there so it doesn't roll. And then we switched to the transgastric view actually to close the device. But what we've already seen is that the lateral, so the P1 isn't really in. So that's why we just lifted the clasps, we are a bit repositioning there. And if we don't have good visibility of the P1, as we just had in the RV inflow-outflow, then we usually switch to the grasping in the transgastric view. And I really wanted to go as posterior in the P1 segment as possible, but as Nina just said, it's not that broad. So, yeah, you can already see that on the P1 segment, the posterior part is already immobilized due to the pedal. And now we go into a capture-ready position, and we will perform the clasping in the transgastric view. Yeah. So now the capture-ready position, 180 degrees, and now the slider is going down, and we have just captured the P1. Actually, we wanted to achieve a rather 2:30 clocking than the 3 o'clock clocking we just did, so I'm rotating a bit towards the 2:30, but we usually don't do great movements after we have already clasped the lateral. And you can also already see that the septal is already on the paddle, but we had good visibility of the septal leaflet, and that's why we switched back to the RV inflow-outflow view to get a really good view on the leaflet insertion. So the leaflet is already on the paddle, but we don't know how deep because I pulled up a little bit too much. So this is the septal leaflet, and we're doing the clasping now of the septal leaflet. You have seen the clasp coming down, but I think I thought we should improve it, just go back really to the hinge point of the septal leaflet, what we achieved now with a second attempt. And we are closing the device, and this is the result we got. But we weren't sure about the tissue bridge of the P1 because there's some mobility anterior to the device, and that's why we decided to do the grasping of the lateral again. So what we did, we can discuss that. We lifted both clasps. So we could have kept the septal, but I usually don't do that because it doesn't really make much sense to me to the kind of reverse Tarzan. And so this is the third and hopefully final grasp. This is again the transgastric view where we usually close the device, as you can see now. And you can see that we have a nice tissue bridge between the P1 and the septal. We do have some residual TR, which originates posterior to the device and also a bit between P1 and P2. So, yeah, we thought if we could improve that, but didn't really have a good idea about it. So this is the residual TR we had. And as we didn't have any great alternatives, we thought we would accept that. But if you have suggestions, we can discuss it, obviously. So we are unscrewing the suture lock again of the PASCAL Precision. And then the blue release knob, as we just did before. So this really changed from the Gen 1 to the Gen 2. And now this is the release. And again, we're fixing the steerable and unflexing and advancing the guide so that we are central in the right atrium. So if we want, we can also do another device. So this is the final result. We have the gradient was 1 millimeters of mercury even after the second device, and this is the final TR we got. So this is the maximum we had. And to sum things up, this was the discharge echo we had. It was obtained 2 days after the procedure. Really searched for the largest jet, which you can see on the left. And yeah, so this is the final result.